Good morning. My name is Mary Leonard, Chair of the Department of Pediatrics. As always, delighted to welcome everybody to Pediatric Grand Rounds. This is going to be the first Grand Rounds in, I think, 4 or 5 weeks. It's not about COVID. I think many of you may know that our ICUs are still full and our great quality work is still ongoing. And we have a great panel of people who've been doing incredibly impactful work around quality improvement. And so I know Elaine Donnelly, who will, I'll pass the baton momentarily, and we'll introduce all the people. Elaine is our Chief Quality Officer. So we look forward to hearing about that and want to welcome the panelists shown here. Looking forward, I want to draw your attention to next week's Grand Rounds on telehealth in the era of COVID. I think you all know that this team is, setting land speed records for the responsiveness to the various processes coming out of the command center, coming out of something called court. And every time they change the testing criteria or anything that happens, the EPIC team needs to operationalize that. And so very grateful, but at the same time, there's really important work with telehealth going on, not just around our clinical mission, but in terms of education and as well as research. We have multiple faculty who are doing research using telehealth, and finally also work around advocacy. So every piece of our mission is being facilitated by Natalie Ceylon and their team. And so we're going to be hearing about all of that work next week. Coincidentally, Bonnie was on the schedule to come give us the Red Book vaccine update. I'm sure some of you know that she does chair the Red Book committee, and this is an annual event, the vaccine update. I had the pleasure this morning, just over the last hour, Bonnie gave a presentation to all the clinical department chairs around various research studies that are launching from prophylactic medications in the outpatient, medications on the inpatient, and for the inpatients, as well as vaccines. So we may hear a little bit about that work as well as the Red Book vaccine update. Bonnie has so many extraordinarily innovative epidemiologic studies that are just taking off. So we've asked her to come back to us as soon as she feels like she's ready to share some of that information. So you'll see Bonnie on the schedule soon. So finally, I want to make sure everybody knows that you can type your questions in the Q&A at the bottom of the screen. I track on all of those during the Grand Rounds presentation, and will help moderate the Q&A at the end. So really encourage people to take advantage of that opportunity to ask your questions throughout the presentation. So with that, I'll pass this along to Lane, who's our Chief Quality Officer. Also has been doing really impactful work in COVID around testing, helping us roll out our electives, all elective surgeries, all the sorts of things that are underway right now. And Lane has been our conduit to much of that work. All right, Lane, you want to take it away?
Thank you, Mary. Hopefully everybody can hear me. Welcome to our annual safety lecture. And as has been stated, we've chosen a topic for this safety lecture around improving safety in central venous catheters. And I just wanted to say a couple things about the genesis of this initiative and introduce the team. This initiative came out of a common cause analysis of significant events that were identified through our professional practice evaluation process. And it was determined that one of the items that was associated with significant patient harm more than other things was the placement of central lines. So this initiative was born to improve safety around placement of central lines. This is different than our work that we talk about a lot around collapse or central line associated bloodstream infections, where we try to keep those lines from being infected. This is more focused around the placement of lines. So when this was identified as an issue through the common cause analysis, an initiative was created and a team put together to try to put together key drivers to improve the safety around this. And that team was led by Shellie Josephs from Interventional Radiology and Andrew Palmquist from Nursing Leadership, and included they and others who will be presenting today, Lisa Bain from Neonatology, Kate Steffen from the PICU, Andy Shin from the CVICU, and Tom Caruso from Anesthesia. So with that, I will turn it over to the team to present.
Thank you, Lane, for that introduction. So what I'd like to talk about a little bit is, again, just in general, mechanical central line complications. So this was really a pivotal study that came out in adults back in 2003. And so when you look at this study and the data that's available here, you look at the frequency of mechanical complications of central lines, and they're as high as 6 to 19% in some of these. If you look at the year that this study was put out, it was 2003. So you have to assume based on that year that this was before the time that ultrasound guidance was universally used. So the things that we're going to talk about really when it comes to mechanical complications of central lines are the occurrence of arterial puncture, pneumothorax, hemothorax, which is blood in the chest, air embolism, which we're going to just barely touch on, arrhythmias, and then catheter tip malpositions. These are the ones that are really kind of within the group that we're going to be talking about. Here at LPCH, one of the things that we know is that we put in lots of central lines. So this is just our data from 2014 to 2018, looking at the number of central venous catheters placed. This number is all encompassing. It includes PICC lines and central lines. But again, in general, there are over 2,000 lines placed per year. When we look at the complications that we saw, they're actually really very, very rare when we look at 2,000 lines per year, but they're very dramatic and memorable, and they do definitely cause patient harm. And that's really what led to the development of this group, looking at what we can do about it. So this is just an example. This is a 9-month-old that came in, really a very, very sick, acute child, had a subclavian venous catheter placed. And if you see the image on the left, those of you who aren't radiologists, I will tell you there's a very large pneumothorax. As you can see, the heart is pushed to the left side of the chest, telling us that that's actually a tension pneumothorax. And that's actually related to the placement of the catheter. On the next film on the right, you can see that a chest tube has been placed. All that dark lucency that was there that tells us it was a pneumothorax is actually gone. But the other thing that you can identify is that the catheter does not look like it's in the right place. It crosses the midline to the left side. So not only did that catheter cause a pneumothorax, but the catheter is also in the artery. And so if any medication was given through that catheter, that could actually cause significant harm, including the risk of stroke, because that any type of precipitate would actually go up to the arteries to the brain. So this is a very, very serious complication in this child. And we have to be able to actually remove the catheter too without creating harm. This is another patient, again, a patient who was admitted for acute liver failure, had a severe coagulopathy, meaning the blood was just really not able to clot on its own. If you look at the first film on the left, the first film for placement, you can see up at the top of the chest near the catheter, there looks like the space is a little bit widened there. That is actually a hematoma. If you look at the next film, an hour and a half later, when the patient was acutely decompensating, we have what looks like a large hemothorax. The catheter is shifted over towards the other side so that you know that there is an ongoing complication occurring. On the CT, hopefully the pointer works, but you can see this little dot right here. And as I show through the CT scan, again, the central line is actually in the vein. It's in the correct place. However, one of the things that has occurred is that before going into the vein, the artery was inadvertently punctured. And in the location of the puncture, it was not in a place that you could get hemostasis just by holding pressure. So these are the kind of things that we would really want to avoid. When we look at different risk factors for mechanical complications, most of the studies have actually been done in adults. And all of those point to previous surgery, prior IVs or prior central lines at the site, lack of expertise, patient factors like obesity or a small neck. And if we think about that in children, again, a lot of our infants are not obese, but actually short squatty necks is a very frequent finding in infants. And then multiple attempts at cannulation. And when you look at the use of ultrasound as something to reduce those mechanical complications, again, it has been definitively shown in adults to reduce the number of needle passes, to reduce the time it takes to cannulate, and to increase the procedure success. Other items that have been shown to decrease mechanical complications are the use of mechanical checklist, as well as some type of systematic training and skills assessment for our trainees. A very interesting study, again, this was also on adults, that looked at mechanical complications based on the number of attempted punctures and was really quite striking. This was actually a really quite a large study. And when they had one puncture, the complication was approximately 17%. One of the conditions that they also considered a complication was failure to place the line. So that with one puncture, the complication was 17%. By the time they got to 3 punctures, the complication rate was up to 54%. So that is really quite dramatic. So anything that we could do to increase our skills, increase our success with puncture, actually should increase our safety. In children, there are actually really very few studies. Most of them are very small studies, really somewhat individualized, but this was actually a meta-analysis that actually looked at ultrasound guidance for central venous catheter placement, specifically in children. And out of 8 studies, they were able to show that the use of ultrasound increased the success rate by over 30%. And what was clearly shown was there is a decreased number of attempts, and as we've seen, that should decrease our risk of complications. And again, this showed just a trend towards decreased risk of accidental arterial puncture, but that was because it was actually very rare in most of these studies. And that ultrasound actually was beneficial for both people who had a lot of experience as well as those who were just learning. So as Dr. Donnelly pointed out earlier, again, we identified a few cases, really not very many, over the years that have shown that we can cause severe patient harm by placing these catheters. And we identified that there was an opportunity to have evidence-based standardization of our process across the hospital, including everybody, for central catheter selections. And not just selection, but also the insertion technique, confirmation, and then training across all of these specialties. So of course we developed this A3, and we had a large clinical group looking at this, divided into multiple subcategories. And again, the most important part of the central lines actually really comes with determining that you need a central line. So Lisa Bain will talk to us about their work in looking at the determination of the necessity. And you can see within this group, again, we have people from multiple specialties who all work together to agree with this. Line selection will be presented by Kate Steffen from the PICU. And you can see within her group, again, people from all different subspecialties within LPCH were very involved with the determination of these. Tom Caruso from anesthesia will talk about technique, and then training and oversight will be presented by Andrew Shin. And once again, if you look at this list of all the people involved, you can see that across the hospital, every specialty has been involved along the way. So this is really something that involves all of the teams and will apply across the whole hospital. Our champions, of course, were Dr. Donnelly and Christy Sandberg. Krista Bernacki, of course, was essential because a lot of this is really going to be reinforced through EPIC builds, which we'll discuss a little bit later. And then Tua Palongo. So once you have this many doctors involved, you have to have somebody who can crack the whip and actually keep us all going. And so Tua was definitely the person who kept everything moving. And so we really appreciate all the help that all of these people have put into this project. One of the things that we really wanted to have at the end of this was actually a clinical pathway. And so this will be presented here later as we go through this, but most of the slides that you'll see are all based around the clinical pathway that we've developed that we will have really enacted and try to put out across all the different specialties. And so Lisa Bain is going to start talking to us initially about our determination for need for central catheter, because that's really the most important thing. If we don't need a catheter, we won't have complications. And so here's Lisa Bain.
Thank you, Shellie. So as Shellie said, my group was really focusing on standardizing when you need a central line. And in addition, we looked at when you should not be putting a central line in. And together we can help you determine when a central line is indicated, when it is contraindicated, and when you should get by with just a peripheral IV. So first, these are the indications that my group determined for the need for central lines. So central line only or preferred medications, which can be looked up in the formulary or in discussion with your pharmacist. IV access when it's needed for a prolonged period of time, and we left this range wide for many reasons, but 5 to 14 days to use your clinical judgment with a certain type of patient. Nutritional support, so central TPN requires a central line. If there are multiple incompatible infusions, one might consider putting in a central line, or frequent phlebotomy or difficult access. And we have a sidebar to help people determine when IV access is difficult. And then when you need central venous pressure monitoring, or obviously emergency IV access. And then for certain cases of renal replacement therapy and pheresis. This is a short list of relative contraindications, and we left the word relative in there on purpose because there's often extenuating circumstances in which you need a central line anyway. But if you see one of these contraindications, you can use your clinical judgment to determine if it is still safe to put in a central line. So diabetic ketoacidosis, coagulopathy or thrombocytopenia, a hypercoagulable condition, systemic fungal infection, and chronic kidney diseases are all relative contraindications, which then require clinical judgment to determine if you need to move on to a central line. And so when we put these all together, there's a nice flow sheet for people to go through to determine if there is an indication, and if there is not, to continue with peripheral IV access. If there is an indication, to then think about the relative contraindications and whether it is safe to proceed or whether we need to go back and use peripheral IV access. And then if it is determined that a central line is indicated and not contraindicated, the next step is to determine what type of line to put in. And for that, I will pass it to Kate Steffen.
Thanks, Lisa. So our group was faced with multiple different considerations in terms of determining the type of line that needed to be placed, the location of insertion, the size and the length of the line, and the number of lumens to be included. Some of the things we needed to think about were the indication for access, how urgent access was needed, the severity of the patient's illness, and how long the line was needed. We were also asked to think about things that were related to the patient context. If the patient was at risk for an active infection, if they had a risk for bleeding or a history of thrombosis or current thrombosis, if they had some sort of anatomical abnormality that would prevent us from accessing the neck or groin, if there was something going on with the patient's specific disease, specifically a mediastinal mass that may make access difficult, if the patient had developmental or behavioral considerations that would sort of guide our ability to keep a line in safely, and if the patient had a history of prior access and potential need for future access. Because there were multiple considerations, we looked at the literature to sort of see how to frame this, our set of recommendations. The thing that we found most helpful was the MAGIC, I guess it's a panel that used the RAND UCLA appropriateness method sort of to come up with recommendations for line placement in adults. And so you can see here that the group determined different sort of time length categories for specific types of lines. This group actually has an app that is available. It's actually a pretty sophisticated, handy app, although it does apply to the adult population. We liked this approach and sort of started our process using this thought process. So the first thing is to determine the type of catheter that is necessary, is to consider the duration that the line is needed or the therapy is needed. So we have different time buckets that patients may fall in to determine what line is indicated. And you can see here, they're listed in order of preference. In cases where the lines would be considered equally effective and indicated, they're both listed under the first box. We also created a category for patients who may need home IV therapy because some of our patients do require this, and there are different lines that might be indicated in these cases. In this particular chart, we also factor in developmental and behavioral considerations for patients, since it made sense to do so here, as well as whether or not the patient needed hemodynamic monitoring. After we thought about sort of the duration of that the line was needed, we also wanted to think about other indications for therapy. So things like emergent access would require a different type of line, a non-tunneled central catheter, as opposed to any of the other catheters that could take a bit longer. Similarly, the type of therapy that the patient was receiving, whether or not the patient needed dialysis or apheresis, or other considerations like the risk of active infection or need for hemodynamic monitoring factored in here. And so this chart is meant to sort of provide guidance in terms of selecting the type of line indicated for the particular indication for the patient. Next, we wanted to provide guidance about the size of the central catheter that was indicated. The large chart is fairly detailed and not meant to be memorized, of course, but there are some central principles that we would want people to think about when placing line. The first is to maintain the catheter to vein diameter inclusion ratio of less than 50%, meaning that we wouldn't want the catheter to be more than 50% of the internal diameter of the vessel that it was going to be placed in. We also want people to think about whether or not the patient has a history of prior occlusions or thrombosis. And if the patient has other existing lines, as this information may guide the size of the line, certainly, and potentially the length of the line selected. Again, the chart below is meant as a reference to provide guidance in terms of selection of lines based on the patient weight, and is pretty handy for placement of these different types of lines. Next, we wanted people to consider other sort of specific contextual factors that may, again, guide sort of the placement of the line. Things like high bleeding risk and recommending that providers access the most safely accessed vessel. In this case, for a patient at high risk of bleeding, selecting a site where bleeding could be addressed with pressure if it were to occur. In the case of our patient had prior thrombosis or frequent lines, to recommend image guidance is always used. In patients who need future access, to follow vessel preservation strategy, which I'll discuss next. If the patient had a mediastinal mass, to assess for vessel compression or inclusion in the upper body, and the recommendation that femoral access may be necessary if there is compression or inclusion of multiple vessels. If patients have some sort of thing that prevents easy access in the neck, or something that would prevent access being maintained in the neck, like a C-collar, if they had cervical instability, needing to be maintained on CPAP that has straps around the neck area, a tracheostomy, or other mechanical issue with the neck, to consider femoral, subclavian, or PIC rather than the IJ. If the patient has diarrhea, skin breakdown in the groin, to think about placing a line in the upper body. And then if the patient had developmental or behavioral issues, to place the line in the area of lowest risk for inadvertent removal. Finally, this is our strategy for vessel preservation. In patients who have these specific issues or needs, we would recommend different sort of line placements. The lists are in order of preference, and so for a patient with chronic kidney disease, we would recommend preferentially using the IJ over the subclavian or PIC, in this case, given the patient's need for future access and potential dialysis. Similar recommendations are made for patients on chronic TPN, with single ventricles, or the anticipated need for ECMO. And so this sort of concludes the area about line selection, and next, Andy Shin is going to talk about training and supervision.
Hi, thanks for this opportunity. My role and the team that we oversaw in terms of standardizing the role of supervisors was to try to understand and develop a set of standard operating procedures when it comes to the placement of central lines in the setting of having a supervisor and a trainee. This touches upon, I think, a very important topic about the intersection between trainee autonomy as well as patient safety in an academic teaching hospital. I think for the most part, the literature very much supports the fact that teaching hospitals have carefully balanced both agendas with demonstrable results that show that there's non-inferior outcomes or even superior outcomes associated with teaching hospitals compared to those with non-teaching hospitals. But we felt as a group, specifically when looking back at our data and our outcomes, that there's an important opportunity to try to mitigate many of the risk factors associated with mechanical complications related to central venous catheter placement. And so this standard operating procedure really is meant to articulate what that SOP should be in the standard placement of central venous catheters when it comes to the supervision of trainees. I have a lot of gratitude to the multidisciplinary team that really developed the standard operating procedure and was really meant to capture the safest approach, but also really keeping in spirit our mission as an academic teaching hospital to make sure that trainees have appropriate opportunities for education, for developing skill sets, as well as having the appropriate and adequate amount of oversight and governance when it comes to the safe placement of central venous catheters. So in terms of what who the qualified supervisors really are, I think it's important to kind of clarify that terminology a little bit. So we feel that qualified supervisors are certainly the attending of any particular unit that's credentialed in the placement of central venous catheters. We feel also that advanced fellows, defined by the completion of a advanced training program in intensive care, anesthesiology, surgery, and cardiology, are also qualified supervisors who can oversee residents and early fellows in terms of these oversight of central venous catheter placements. And we also have, I think, a wonderful team of advanced practice providers with an extraordinary amount of depth and skill when it comes to their experience when it comes to central line placements. And so we feel like those who have within their scope of practice defined by hospital credentials and central venous line placements to be adequate supervisors for residents and trainees as well. Again, just to clarify some of the terminology, there is a distinction between direct supervision and indirect supervision, and that's clearly defined by the American Council of Graduate Medical Education as the supervising physician. The direct supervision is a supervising physician who is actually physically present with the resident and the patient at the time of the procedure. Indirect supervision is defined as having direct supervision immediately available within the hospital or other site of patient care, and is also direct supervision is available, not physically present, but within the hospital, immediately available, again, by telephone or another electronic modality. In regards specifically to the supervision for placement of central venous catheters, we feel that these are the indications that kind of adequately tries to mitigate some of the complications associated with the placements that we've experienced here at LPCH. I think this is relatively non-controversial, and meant to really capture our current scope of practice, but to really articulate it, we said that any large bore catheter placements, such as a hemodialysis catheter or vascular sheaths, require direct supervision. Direct supervision is also required for any subclavian line placements. Patients with known limited vascular access options or difficult vascular access options. If the access attempt has failed by more than 2 or 3 times, central venous access is to be performed by any resident fellow not designated as an advanced fellow. And direct supervision is also required for patients considered to be at high risk for bleeding complications. Here we tried to think about any particular numbers or thresholds, but we feel like functionally and the assays don't always match up, and we feel that if there's a functional high risk for bleeding, that requires direct supervision for any particular patient. Indirect supervision with a supervisor present is for a confirmation of vessel prior to puncture and confirmation of wire placement into vessels. And indirect supervision is also required for confirmation of the catheter tip position and confirmation that the catheter is ready for use. And I'm going to pass this now on to Tom. We'll talk a little bit about the safety checklist procedures.
Thanks, Andy. So our working group looked at the technique of central line placement, and we certainly don't aspire to teach you how to place the central line, and we certainly recognize that within different populations, whether in interventional radiology, anesthesiology, in the ICU, we have some heterogeneity in the techniques that we use, and that's okay in most cases. Accompanying this project is a pathway that Dr. Joseph alluded to, and you'll see some of these pathway checklists pulled out in the slides here. And in this slide, what you see is the CVC Placement Checklist to think about pre-procedurally. Anatomically, there are a couple of things you can do to reduce the risk of a mechanical complication. One is understanding that as you turn the neck for internal jugular placement, you may have a anatomic perturbation of the relationship between the vessels, specifically the carotid artery and the internal jugular. You'll see on the right side of the slide there that having these vessels placed side by side, as opposed to having the internal jugular atop the carotid artery, is going to help you, and the placement of the central line reduce the risk of going through and through the internal jugular into the carotid. And oftentimes this can be mitigated by simply reducing the turn of the head. So doing a pre-procedural ultrasound scan is very helpful. Additionally, having the patient in the Trendelenburg position might seem pretty intuitive at this level, but just to call it out, is going to help increase the diameter of your internal jugular during placement. During the technique, there are a couple points and tips we just wanted to call out. One is that try to avoid entry very close to the clavicle when placing an internal jugular line. We're focusing on that since that's the most common line placed, to minimize the risk of pneumothorax. It also provides easier needle visualization if you don't have the clavicle as a bone in the way of your ultrasound. We also recommend a single operator have only 2 attempts before the CVL monitor reads a scripted statement. 2 attempts have been made. Should we reassess the plan? Is the patient optimized for position, sedation, equipment? This is important and goes back to what Dr. Joseph mentioned at the start of the talk, where going from 2 attempts to 3 attempts, you really see an uptick in the number of complications. After 3 attempts or more, you have almost 50% risk of having a complication. And to avoid errors of fixation, it's very important to have a pause and to understand what is going on in this situation. Perhaps a different site, perhaps a different operator, and maybe we need different equipment, different needles to make this be a successful line placement. During the dilation and insertion of the central line is when you're dealing with the wire. Now there's a couple instances that occur when placing central line, and one of them is retained wire. And this is always a complication that we seek to avoid always. So a couple things to avoid that is having 2-person confirmation of the wire removal. I myself like to take a picture of the wire and put it into Epic. So it seems a little unusual to have a picture of the wire afterwards, but because I have to take that picture of the wire in my mind, that ensures that, hey, don't forget that wire. You're going to take a picture of it when you're done. That's just a personal habit. That's not part of our pathway. Additionally, when you're placing the wire, ensure that you rotate and twist the dilator that the wire is in at the site of the skin. If you're rotating and twisting at the distal end of the dilator, you may kink the wire. And sometimes this prevents being able to pull the wire out after you've placed your central line. And always control and maintain control of your wire. Confirmation prior to dilation. We have had instances where people felt on ultrasonic view that the wire was definitively in the correct vessel. And this does rely on a single modality, that being an ultrasound. And occasionally folks will use both the short and long access using that ultrasound to obtain a view. And they'll also use Doppler to ensure that you're in the internal jugular, not the carotid. However, if skill of the ultrasound is not at an optimal level, it's possible that an additional modality to confirm placement would be helpful and may have avoided the complication of an inadvertent arterial placement of the line. We recommend having 2 different types of confirmation. One from the ultrasound, whether it be an image of the wire in short or long access, or using a Doppler to look for pulsatility. And another one from a second category, which could include manometry, fluoroscopy, a venous blood gas, TEE, or X-ray. Within the pathway, you'll see a summary of everything that we're talking about here, placed in a checklist format for easy reference. I'm now going to turn it over to Andrew, who's going to go over the safety monitor role and bring us home.
Good morning, everybody. As a clinical leader involved with vascular access and critical care for some time, I, as well as my nursing colleagues, really appreciate being a part of this process improvement quality initiative. The vascular access team here at Lucile Packard has much passion and advocacy around using cutting-edge evidence-based practices for central lines. Recognizing the majority of what we do in the hospital to treat and heal patients occurs intravenously. The work we do that we're discussing today not only helps mitigate the safety risk related to the procedure itself, but also has a larger impact on safety and health for all the downstream effects around central lines. Right line first time has long been our mantra. To incorporate these best practices, best new standards, we'll be introducing a central line safety monitor role. This role will be staffed either by a bedside nurse, who majority of time is already needed to monitor sedation, or can be any supervising or other available provider. The central line safety monitor will be working off a laminating checklist that will be attached to each central line cart that really calls out all these elements that we're talking about today. The first step is to note that there's a dedicated sedation CVL safety monitor in place. Next, we'll be utilizing an expanded central venous line timeout to include following items that have been discussed previously, such as patient risk factors, having an appropriate proceduralist and appropriate supervision in place. The next item on this safety monitor checklist will be pausing after 2 unsuccessful attempts. We really hope that by engaging a larger team and being more transparent around the number of folks, we can shift the culture to make people feel at ease at really calling it out and are providing some standard scripting to help with this. The standard scripting will read such as, 2 attempts have been made. Should we reassess the plan? And then considering the following, as Tom just talked about, looking closer at positioning equipment, sedation, presence of hematoma, or escalating to a different provider. Next on this safety checklist will be focus on wire counts, as also was mentioned as another important safety aspect. There's actually a place on this laminating checklist for people to note the pre-procedure wire count, any additional wires that have been added throughout the procedure, and a post-procedure wire count. The next step on this checklist would be confirming 2 techniques of vessel confirmation prior large sheath cannulation. And this can be done through ultrasound, x-ray, or fluoro, potentially a blood gas, or pressure checks. Next, and just to finish off the list, would be a post-insertion central placement confirmation through one of your x-ray or ultrasound techniques, and then proper dressing the line and starting maintenance fluids as needed. As part of these additional safety check items will be embedded in the central line timeout in a very quick central question that encompasses many of these elements, so it shouldn't be too much labor to chart additional items. There's also going to be 1 or 2 minor changes to the insertion note that help pull out some quality aspects related to central lines. Although there will be more opportunity related to safety and utilization of the medical record to prompt the central line selection choices and tracking of quality metrics that could be shared through different quality groups and collaboratives, this work done really provides a foundation for best practice standards and also shifts the safety culture in the right direction. So in summary, understanding central line complications and risk factors, following the new clinical pathway to guide necessity, line type, size, following the best practice insertion techniques, and helping to support an increased culture of safety related to supervision will help promote safety for both the procedure itself, as well as many other related safety and health implications that are improved by these new standards, placing the right line first time. So with that, that concludes what we have to share with you today, and we'd like to open it up for questions and discussion. Thank you.
All right, thank you. So I want to extend my congratulations to all the panelists for very thorough, evidence-based and actionable guidelines, and very nice multidisciplinary team. So there's just a number of questions. I'll just start with a very practical one, and that is, where can I find the pathway?
Sure. So we're going to have it on the Clinical Pathways website, which can be accessed through Epic. And people should be familiar with that. And that's the library where all clinical pathways are housed.
Great, thank you. If I was trained differently than what is recommended, is there a process for additional training?
The most important differences within this whole concept is actually the use of ultrasound. So if there is somebody who is not comfortable with the use of ultrasound and is actually approved as a provider for central venous catheter placement, and we will try to afford ways that they can come and learn about ultrasound. We are happy in interventional radiology to have people come and see how we do it. And I am sure that there will be other people within all of the ICUs that will also be happy to help train and assist. And our goal is to be able to roll out, even at the faculty level, just reminders of the importance of placement of central venous catheters. And many of those steps are still to be worked out, but again, whether it is an additional piece that comes with our recredentialing, those are some of the considerations. And once again, that won't necessarily be training. So if somebody feels like they need training, I would highly recommend that they reach out to me. Again, we're happy, we do it every day in interventional radiology. So we have plenty of access to patients, and we're happy to demonstrate techniques with ultrasound. The other differences that Tom discussed are really very subtle. So if somebody is already comfortable with ultrasound guided puncture, really it's just a matter of confirmation that they are where they think they are with ultrasound. So confirming in 2 views, the wire placement, confirming whether they need blood gas, the site of puncture, making sure that we're looking at the IJ compared to the subclavian, because again, there is a different level of safety there. But again, for people who feel like they need additional training, we are happy to provide that.
All right, thank you. Oh, sorry, somebody want to add to that? Okay.
No, I don't think so.
All right, thank you. So in follow up to the part about ultrasound, someone wrote, femoral access is frequently obtained without ultrasound guidance with multiple more than 2 passes before ultrasound is considered. Did the group also look at sheath placement for cardiac catheterization? Sorry, the femoral access frequently obtained without ultrasound. I think that's in the context of cardiac cath. So did the group also look at sheath placement for cardiac catheterization?
Recommendations for these guidelines are across the institution. So the only thing that is excluded from these recommendations is PICCs and umbilical venous catheters. So that being said, I'm an interventional radiologist. I use ultrasound for every puncture that I use. It has been shown to be safer. There are some studies that have shown in very experienced operators. There was an anesthesia study in pediatrics that actually showed in very experienced anesthesia operators that they actually were safer doing it with landmarks compared to ultrasound. But that is not replicated amongst different layers of training. And so the ultimate goal is that this is an institutional process, that ultrasound is used when we are doing obtaining IV access, or not IV access, but central venous access.
Great, thank you, very helpful. What is the group's opinion on midline catheters?
So we did think about midline catheters in part of our process and ended up not including them as they're oftentimes, I think, placed by our PICC line team and have their own considerations. I'm realizing now that this might be something we do need to make some comments on, and so we may consider some modifications. I don't know what specifically the person asking the question wanted to know about them, but we will potentially address issues in the final document.
Okay, so somebody wrote regarding midline, so maybe this will help with some, elaboration. I'd also like to know the data, including definition of midline. If you consider venous flows in a given vessel, I'm not convinced midline is inferior to central in many cases. Okay, we're getting very technical here.
I think that sounds like one of my vascular access nurses, but that's okay. Again, I have multiple opinions on midline catheters. In general, the use of midlines is more helpful in adults. However, in pediatrics and kids, especially in little kids, many people consider the longer IVs actually as midline catheters. So anything that may be longer than our typical 1-inch type IV line. When a catheter terminates in the axilla or in the mid subclavian, the blood flow is not as good, especially in children. And so there are many additional risks of thrombosis that go with those catheters. And if they terminate still within the arm vein, then they probably are good. But again, that was sort of beyond the scope of what we were looking at in this group, because this is really truly mechanical complications. Again, thromboses are sort of a mechanical complication of central lines, but that was actually really not one of the ones that we included within the group that we're looking at. If we did include thrombosis, of course, in children, we would have, a much, much higher rate of considering that a mechanical thrombosis. But that goes with our selection of line placement, or our selection of the vein that we use, as well as the catheter that we use, trying to make the smallest catheter possible and the largest vein possible.
Thank you. So here's a question I think speaks to maybe some confounding in the interpretation of the data you presented. So 3 attempts is associated with increased complications. That is frequently because patients that are hard to get access on are more likely to have complications. Yes, more attempts cause complications, but also more complications, challenging access patients cause more attempts, or maybe are associated with more attempts. Anybody want to comment on this data?
Again, completely agree. So, in patients who are identified as difficult access, every consideration should be made to making sure that you have a skilled individual placing that access.
Right, well said. Okay, central lines are associated with many complications. One that should be addressed is CVL-associated sleeve thrombi or intramural clotting. Okay, now we're getting really technical. Do you add heparin to the infusion to prevent some of these clotting issues?
I will let Andy address that one.
Get in right up close.
We are trying to maintain 6 feet from each other. Just
yeah. Oh, good.
That's a great question. We actually have a very difficult time when we studied this as a group, and I specifically want to mention David Axelrod, who did, and Alan Schroeder, who did a randomized control trial on this particular topic. It's very difficult to capture the incidence of this particular issue when it comes to sleeve thrombosis, because we don't routinely screen for it. And when we do look for it, we tend to kind of have a selection bias on patients who are relatively symptomatic with it. But in the study that was performed that specifically looked at the incidence of thrombosis and the efficacy of heparin, at the time the study was using heparin at 10 units per kilo per hour to try to prevent the incidence of thrombosis and thrombosis-related central line complications. They found that there was no effect or no significant difference in the incidence of thrombosis with or without the use of heparin to prevent that. The study was careful in terms of its inclusion criteria and limited it to patients who had a central venous line for a period of 14 days. So we can't really make comments about the efficacy of heparin beyond 2 weeks, which a lot of patients tend to have central lines for a very long time. And so, so there's no real commentary about the long-term use of heparin, but we can say that probably in the short-term period, within the 2-week period of a central venous line, which I think majority of the catheters tend to be, the efficacy of heparin to prevent thrombosis was shown not to be efficacious.
Thanks. I just want to make a side comment as I'm tracking this. We've had over 150, even more people listening to this. So I think this is wonderful that we're disseminating to such a broad community. Please note this is being recorded and will be posted. So please feel free to share with your colleagues who might find this useful. Simple, a yes, no question, I hope. Is ultrasound available in every case?
Yeah. The answer is yes to that.
Good, thank you. That's what I would have guessed. Okay, what are the best practices for confirmation of umbilical venous catheter placement? Chest X-ray, blood gas, or maybe other?
So this project did not review umbilical catheters, but I'll answer anyway. Typically in the NICU, the best way to confirm is with a 2-view X-ray. In special cases, we sometimes use blood gases as well, but I would say the vast majority of the time it's with a 2-view X-ray for confirmation.
My question is about the time and extra maneuvers it takes to complete the 2-factor confirmation prior to dilator placement. Are there complications related to keeping the wire in the vein for longer time and or extra manipulation to place an IV first and then change it out for the dilator?
I don't know if there's data on if you keep the wire in a little bit longer while getting a second confirmation, what are additional complications from keeping that wire in there? Clearly, if the wire is sitting in the atria of the heart, you may have complications, but oftentimes if you are getting ectopy, you'd want to pull back the wire a little bit anyways. Oftentimes, some of these second confirmation methods can be laborious, right? Like if you want to get a chest X-ray, for example, while the wire is sitting in there, that could be challenging, right? But others, such as doing manometry by hooking up the pressure tubing that comes in the central line kit and simply holding it up to gravity and making sure it doesn't squirt up to the ceiling if you're in an arterial line, can take moments, really. There are options that do not very much prolong this experience. And we did find that some providers do, using a small gauge catheter, draw a VBG or an ABG, and they found, hopefully it's a VBG, and they found that to be very helpful because that's a data point that they're actually looking to get regarding the care of the patient as well. So yeah, it's a little bit of extra time, but the complications of having a dilation of a artery or a infusing medicines through an arterial central line are also very high as well. So those risks have to be weighed against the increased duration of time it takes to do that.
All right. Can optimal catheter tip location be clarified? Some groups strongly prefer PIC tips not be located near the right atrium. Data don't support that practice. I've seen many more problems with vessel erosion when the tip is outside the atrium, e.g. IVC. Oh, and I don't think our community pays enough attention to the thoracic duct. I've shifted to avoiding central catheters in the left upper extremity in kids less than a year.
We recognize there's variation regarding specific patient populations. We did want to share that we have this central line tip confirmation guide that's available as part of this protocol and also currently online in our policy and procedures section. And there is a disclaimer for cardiac populations, but this is typically widely understood as the golden standard. And it starts with the carina. It's making a target triangle where central line placement should terminate. It starts with the carina going down a body and a half on the vertebral over to the right bronchi. And if you can have that as the target zone for majority of catheters, that would be preferred. Although, again, on this guide, there is a disclaimer around cardiac patient populations and whenever there's questions to consult with the attending.
Okay, there's a comment, mini MAGIC, all caps, guidelines are coming out this summer from the MAGIC team. These guidelines will apply to pediatrics. Maybe one of you can tell us what MAGIC is, what that is.
Sorry, I commented on MAGIC at the beginning of my portion, but this was essentially a consensus process that was done in Michigan to sort of guide decision-making around placement of central lines, initially with PIC lines and sort of broadening to other types of central lines. It was a consensus process, so based on literature review and expert opinion. I guess, I'm not going to go back into the slides because that's annoying. But if you access the slides in the future, the reference is there. And again, this group has an app that you can use, all adults recommendations to sort of provide guidance. But we formulated our recommendations sort of based on the, at least the way we're presenting them in the way that the MADRA group did as well. Does that answer the question?
I think so. Okay, yes, I would say so. So a question, an IR question from one of our pulmonologists. For those of us that ask either the vascular access team or IR to place line frequently, for example, the yellow team for the cystic fibrosis inpatients, other than considering actual need for the line, is there anything we should be doing differently? So a nice question from the provider perspective. Yeah, referring
really,
provider.
I think the most important parts are, again, the way that we have it broken down, the duration of the need for therapy, and then in a lot of it, especially the cystic fibrosis patients, is where that therapy is going to occur. Is that all going to be hospital therapy? Are they going to go home for continued therapy? You know, the duration of care of that line, those are really the most important parts of that consideration. So in some of the cystic fibrosis patients who may need, you know, catheters placed, you know, once a month, that may be too much. If we have a golden window where they may be free of infection, if they're coming in that frequently, considering going to something a more permanent line, like a port or something. So again, a lot of those should be discussions with the teams based on the individual. We look at duration of therapy and where that therapy is going to occur as where we're going to choose for placement, but that's an individual event. When you have a particular patient who needs that individual event over and over and over and over, then it's time to start looking at different types of lines that might be more permanent.
Okay, we're in the home stretch here. Just an FYI, David Axelrod, you mentioned his work, Andy, and he says, Alan Schroeder, Alan wrote this paper. Thanks for including me. And the reference to the abstract, there's a link in the chat box. Let's see. This may be a good time to emphasize the importance of all team members speaking up if they see a potential problem during CVL placement. Something as simple as, did that look okay? Or can you teach me how you know that's in the right place? Saves all of us, including the most skilled attendings, from causing harm. So I'm going to guess you all will endorse that.
Yes.
And I think the last one, if I'm tracking this, I did not see immediate follow-up of catheter position, which I feel is an important part of the procedure to exclude pneumothorax, hematoma, and malposition. Procedure is not done until you get a final image to prove there's no complication, also for feeding tubes. Do you agree?
Absolutely, and the slide that we're on right now actually is showing our post-procedure checklist. And again, it's the CVL monitor to confirm appropriate wire count, appropriate dressing, chest x-ray ordered for tip confirmation, and chest x-ray results reviewed and order for CVL use obtained. So absolutely, we 100% agree with that.
Okay, so you get, I think the closing remarks were right on time. I want to thank you. I think the chat box was really an effective way for you to hear from all of the community. Do you have any closing remarks?
Really, I think what we want to stress is, much like the last question, again, this really is a team approach. Everybody in the hospital is involved with these cases. Everybody has the ability to speak up. We want to really empower the people who are there and present to be able to say, you know, this is our time for pause. These events are very, very rare, but they're very memorable and they can be quite devastating. And so really our goal is, through a standardization of the process, that we can make it go from less than 1 to 0 and empower everybody to speak up and keep the patient safe.
Thank you. That's exactly the right note to end on. I just want to, it's a little bit of a segue. Because the ICUs have been considered potentially high-risk environments, aerosol generating procedures, and COVID, I do want to follow up on a question that was asked. Do we know the rate of nosocomial COVID infection of healthcare workers yet? And what PPE regimens tended to fail? So you may see that actually the formal communication actually went out, I think, late yesterday or this morning. that we're offering COVID testing for all healthcare workers, asymptomatic healthcare workers. We first say in the early days when we did have some COVID positive symptomatic healthcare workers, more than 95% were negative, and for the very small number that were positive, all of our contact tracing, and I credit Diane Stafford and Grace Lee for that work, suggested that these infections were acquired outside of the community. So among symptomatic healthcare workers, we don't think any of it was nosocomial. We've tested over 3,000 asymptomatic healthcare workers over the last 3 days. The results as of this morning show that less than 0.5% are positive. Serology data are pending, but I would say with only a handful of positive infections, it's even been stated that our rate may be lower than the general Santa Clara County population, speaking to our attention to good practices. So we are very, very confident that our PPE guidelines are effective. We don't have evidence of nosocomial infections where we could even be able to explore some of the associations. So I just wanted to make sure everybody knew that, those very up to the minute reassuring data. And with that, we'll conclude the session. Thanks for everyone for joining us, and we'll see you next week.
Thank you.
Thank you.